Good morning. After listening to the previous speakers and watching them work under their time constraints, I must confess that I'll have to violate the fidelity of my proposed presentation and make several adaptations. I thought it was funny. Oh, good. I'm going to take a look at the other side of the adaptational coin today. Obviously, the overarching theme of our work here is to look at how we move evidence-based programs into real-world settings. But to do that effectively, we also have to consider how we adapt these programs to the individual needs and preferences of our clients and consumers. And this falls under a label which we call precision medicine. And I'm sure many of you, most of you are aware of how precision medicine is revolutionizing the fields of oncology, immunology, cardiology, infectious disease, and it's beginning to have an influence on drug abuse prevention and mental health. It's an emerging approach for disease prevention, early detection, and treatment that seeks to optimize effectiveness by taking into account individual variability in genes, environment, and lifestyle, also known as tailored health care. But let me also say that what we call precision prevention has generally involved tailoring behavioral interventions to the individual characteristics. It can also involve targeting precise groups or entire communities by modifying care delivery systems, optimizing transmission through social networking, or instituting targeted policy or macro-environmental changes that are different from one community to the next. The advantages of precision healthcare, as I call it, or precision prevention, is that we're able to respond to the wide heterogeneity that exists among our clients, as well as the variability and intervention response that exists among high-risk populations. It reduces negative effects associated with interventions that are associated with burden, iatrogenic effects, and ineffectiveness. Very importantly, it increases adherence, engagement, which has been a perennial problem for preventionists, and it increases efficiency and effectiveness while reducing costs. At the University of Minnesota, we're embarking on this program supported by funds from the National Institute on Mental Health and National Institute on Drug Abuse. And we begin with the premise that many of our interventions work. We understand that. We have generations of research to prove that. But they work modestly. They don't work for everybody. There's question about durability of effects over the long term. They often fail to reach those in most need, the high-risk populations. And even when we get them to the table, participation and completion rates are poor. So we are, within this framework of precision care, looking at new delivery systems and also looking at who responds best to which delivery system. So we're experimenting with different platforms, of which I only have time this morning to talk about two of those, which I call the adaptive intervention and the preference-based intervention. We're also looking at mobile health interventions, just-in-time interventions, new technologies using smart messaging, healthcare coaching. We need to find, we were talking about earlier today about new paradigm. The content is there. We understand the risk factors. What we don't know how to do is deliver. We haven't captured a system that is going to be amenable to the populations we work with across socioeconomic levels, across cultures, et cetera, et cetera. So I'm just going to illustrate two examples. The adaptive intervention tailors interventions over time based upon an assessment of ongoing response. We just don't give an intervention and see who responds and who doesn't respond. We look at that response during the midst of the intervention and make changes accordingly. And then we're going to look at a preference-based intervention in which we afford individuals the opportunity to choose their intervention and see whether or not that improves engagement and outcome, and then based upon results of understanding why they choose what they choose, build what are called decision aid interventions, which try to inform them how to make good decisions about what they need. The first example of an adaptive intervention, we use smart design technology. And this is an example of what it might look like. Keeping in mind now that all of these programs are implemented in real-world systems of care. We're working with leaders of domestic violence shelters, international adoption facilities, welfare and protection, juvenile corrections, and diversion agency. Any place where high-risk children cluster, we're trying to work with them to do these kind of novel interventions. In this smart design, which we ran with a juvenile diversion population of youth aged 12 to 17. It's a very good population to work with. They're at the early stages of problem development, but they're all on different risk trajectories. Some are maybe just low risk and spontaneous desisters in time. Some may be on the fast track to more serious and chronic crime. The agency staff don't know that at the time these people come in, and therefore usually get a one-size-fits-all approach, which probably doesn't work effectively for any of them. So we're trying to create these adaptive intervention strategies that could be plugged in at the front point, and each individual might have somewhat of a different type of form. In this study, individuals are randomized to two different types of interventions. They're both in brief format, 2 to 3 sessions. One is a youth-focused intervention that works on decision-making. The other one is a parenting-focused intervention that works on communication, supervision, and involvement skills. It's brief, and hopefully many of those individuals at low risk will respond favorably and will be stepped down to monitoring over time. However, there will be individuals who do not respond. And by not respond, I'm referring to we haven't changed the risk trajectory significant enough so that they can be just let go. The responders, in some other studies that we're doing, we're looking at different ways to monitor how they do over time using telephone health coaching, using newsletters, using various forms of smart messaging, as I alluded to earlier. The non-responders are going to be randomized a second time. So in the first stage, we look at who responds to which intervention, and the non-responders move on to a second phase where they're randomized to either a continuation, more sessions of the initial intervention, or they're switched to the intervention that they weren't referred to in the first trial, in the first phase of this program. And so over time, you're going to test 4 adaptive intervention strategies. The individual started with teen intervene, they responded and were stepped down. The youth were randomized to teen intervene. They did not respond, and they were randomized to extended or youth extended or parent extended, and the same thing in arm number 2. And at the end of the day, the smart design technology allows us to see how the various adaptive strategies worked. What was the best first stage intervention for non-responders? What was the best second stage intervention? And for those who started with either one, did that facilitate downstream effects? If you started with a youth strategy, did that serve you better in the long run? If you started with a parent strategy, did that serve you better in the long run? I wish I can go into greater detail here, but I'm trying to comply to time. Just wanted to give you an example. This is a dynamic, fluid type of intervention strategy which responds to youth during the course of intervention rather than just a one-size-fits-all approach. I'll skip over this. The second model that I'm presenting here is the randomized preference trial. When we speak of preference effects, we're talking about the growing trend in client participation in healthcare decision-making, sometimes called integrated care decision-making, sometimes called shared decision-making. It is likely that affording individuals the opportunity to participate in the decision about their own care will improve engagement, will improve outcome. It does so by giving autonomy. The opportunity to choose your treatment may enhance your sense of control over the treatment process, over the learning process, within the context of a behavioral intervention, increasing your self-efficacy. Understanding how individuals make decisions about their health care may lead to further intervention enhancements, like I talked about earlier, decision aids, which help individuals make informed choices. This is an example of a preference design where individuals are randomized either to preference or to no preference. Those in preference get to choose which intervention they want. Individuals with no preference get randomized a second time. There are 4 different intervention modalities in this particular experiment. All of the interventions are using the Parent Management Training Oregon-based model. These are children who are referred to mental health clinics across the Detroit metropolitan area because of early oppositional and defiant behavior. The goal is to prevent the onset and progression of conduct disorder. So we have different modalities: an individual home-based model, an individual clinical-based model, a group clinical-based model, and a service-as-usual type of control. In a subsequent study, we've also included an internet-based model where parents can actually receive the intervention at home via logging into their computers. And so you compare how the preference-based model compared with the no preference-based model in terms of engagement, in terms of outcome. And then we look at pre-intervention characteristics that predicted why a person selected one model over the other, primarily motivational cognition-based variables. What were their expectations about health care? What are their attributions about the cause of their children's behavior? What are their belief systems, cultural traditions? All those types of variables may be very instructive in helping us understand why people choose the choice they choose. And if it's a good choice, how can we build that in to decision aids to inform other people about the use of their program? So these are 2 examples of what I might call precision-based healthcare or precision-based prevention. Plugging these into our existing evidence-based models, presenting them in somewhat different ways, may help us in terms of improving engagement, which has been our biggest struggle, getting people to drink the water, and then hopefully this will lead to better outcomes. So I think precision healthcare, as it has in other areas of medicine, offers very significant progress in the areas of mental health and substance abuse prevention. Thank you.